My name is Dr. Zacharias, and I am currently the president of the Ontario Medical Association, which represents more than 43,000 physicians in Ontario. June is Pride Month, and in support of our LGBTQ communities, we want to talk about how the pandemic has affected this population and what the medical community can do to better provide support. The past 25 years have seen progress in LGBTQ rights in Canada, but unfortunately, members of the LGBTQ community continue to experience inequities in healthcare, and we know this. Members of this population have worse health outcomes than their heterosexual and cisgender counterparts. Factors include high rates of stress due to systemic harassment, social stigma and discrimination, and a lack of LGBTQ specific health information, according to Rainbow Health Ontario. Issues affecting the LGBT community have been exacerbated by the pandemic. Medical services have been missed, including testing, treatment, and prevention campaigns for HIV, sexually transmitted diseases, and hepatitis C. Less detection results in more spread. Reach Nexus, a national research team working on how to address sexually transmitted and bloodborne infections in Canada, says syphilis is multiplying aggressively across much of the country. Surges have now been reported in Saskatchewan, Alberta, British Columbia, the Northwest Territories, and here in Ontario. Ontario recorded 2,678 cases of syphilis last year, the highest number in at least a decade, according to Public Health Ontario. The Public Health Agency of Canada says the majority of infections are among gay men and other men who have sex with men, a proportion of whom are also infected with HIV. And then there is the issue of testing. According to a national survey released in March by the Public Health Agency of Canada, testing for HIV, hepatitis C, and sexually transmitted infections has dropped by 45% since the pandemic began. As a result, we simply cannot know the true extent of the rise in sexually transmitted diseases. The federal agency's HIV surveillance report, released in January, showed a 21% decrease in HIV infections in 2020 compared to 2019 across Canada. But again, the decrease could be reflecting the drop in testing, not a decreased rate of infection. What we can say with certainty is that we need to reach those who may be undiagnosed to stop the spread. Many STIs are asymptomatic, meaning more Canadians are unknowingly passing on infections. As well as this, the LGBTQ community has historically faced mental health and substance abuse problems at higher rates than their non-LGBTQ peers. Across the province, wait times for LGBTQ counseling programs are longer than pre-pandemic. At peak times during the pandemic, people waited 9 to 12 months for help. It's really unacceptable. The demand for gender-affirming related surgeries is increasing, and the pandemic has made those wait times even longer as well. The LGBTQ population is growing, and we want to do better to support their healthcare. That doesn't mean one approach for all. LGBTQ people are not a monolith. The LGBTQ community's healthcare needs are as diverse as they are. Our approach to caring for people in this population should recognize individual needs. Now, I would like to introduce 4 guests who we have with us this morning who will share their perspectives on issues faced by the LGBTQ community and how the medical community can better support their healthcare. Dr. Tim Guimond is a psychiatrist at the Centre for Addictions and Mental Health in Toronto. He's also mental health director at HQ Toronto, a new medical clinic for gay men and transgender people in Toronto. Welcome, Dr. Guimond. And welcome to Jack Woodman, is Vice President of Strategy, Quality, Risk, and Privacy at Women's College Hospital in Toronto. They spearheaded the effort to have gender-affirming surgeries available at the hospital. Welcome, Jack. And welcome to Dr. Ed Kocharsky, who's a family doctor and Chief Medical Officer at Casey House, a specialty hospital in Toronto for people living with or at risk of HIV. Welcome. And welcome to Dr. Amy Borns, who's a family physician at Sherburne Health Toronto. She is also the program director for the Enhanced Skills Residency Program in 2S LGBTQ Health at the University of Toronto's Temerty Faculty of Medicine. Dr. Guimond, we'll start with you. Can you please tell us how the new HQ Toronto clinic will approach sexual health given the concerning rise in sexually transmitted infections? What insights can you share about how the pandemic has affected mental health within the LGBTQ population? And how can the healthcare system better support mental health for this community specifically? Dr. Guimond.
Thank you, Dr. Zacharias. So my name is, as I said, Tim Guimond. I'm a psychiatrist and a statistician. I'm here at HQ today. This is a new clinic about to open in July 22nd will be our formal launch. And HQ is aiming to be a center of excellence for sexual and mental health care for cis guys and guys and all trans and non-binary people. So we're going to be providing a convenient downtown destination for HIV, sexually transmitted infection, and bloodborne infection testing. As you can see behind me, to increase convenience, the services have been designed with self-service kiosks. So people will be able to come in, answer some questions, collect their own samples, and the availability of an on-site laboratory will mean that we are able to give rapid results texted to patients' phones within 4 hours of their testing. We think this is going to be a drastic shift. We also have a whole clinic on one side here that is going to have physicians and nurses and clinicians available to treat anyone whose test results come back positive on the same day. We know when they've done equivalent work in other countries, it's reduced the HIV rates because HIV transmission comes down as people know their status and they're able to get treated much more rapidly. We're going to add on the things that people have done in the past by including assessment for eligibility for pre-exposure prophylaxis and post-exposure prophylaxis for HIV. So somebody who comes in and has testing, within 45 minutes, we should be able to get someone started on PrEP, know their HIV status. This is very different than the system right now where you need to wait for the results to go to public health, come back for your doctor to know that we can now start the medications. And so by bringing all of these windows down to shorter periods, we're hoping to be able to address the sexually transmitted infection surge that we expect and to address this under-testing that you were describing. We also think that if we do this, it should be 15 or 20 minutes that it takes for a standard visit to our clinic. This is also going to be kind of revolutionary in efficiency and convenience for people, which we hope will drive up people having routine testing much more frequently. All of that being said, I'm a psychiatrist, so I'm also interested in the fact that HIV, either STI, syphilis, those rates also tend to travel with individuals who are suffering from untreated mental health and substance use problems. And so we've integrated an entire part of the clinic here that also deals with mental health and substance use concerns. And so we'll have a stepped care model where if you come and you request some mental health help, you'll do some self-assessment, and we will stream you to a level of service that matches the severity of the problems you're facing, and support that with peer programming and recreational and social programs that appeal to people in the community to make this a center that helps fight the isolation. So we know very well, like was described earlier, that LGBTQ2S individuals have higher rates of mental health and substance use problems compared to their heterosexual and cisgendered partners, and that has increased during COVID. We know that from one Canadian study by Goodyear that about 25% of LGBTQS individuals report increasing their alcohol consumption during the pandemic, and 19% reported increasing their cannabis use. And this has led to additional problems. So a study by Slayman that was done across our nation, but centered in Vancouver, found by comparing 3,000 adults early in the pandemic in the spring and later in 2020 in the fall, that while cis and heterosexual individuals stabilized in their increased needs, those of us in the LGBT community had continued increased needs and increased difficulties during COVID. So much so that early on in the pandemic, it was 15% of sexual and gender minorities reporting suicidal thoughts, and 23%, nearly a quarter of the sexual and gender minority adults in this study were reporting suicidal thoughts late in the pandemic. So we're hoping to be able to innovate in this mental health sphere and to provide the services rapidly to people, both for sexual health and mental health. Thanks.
Thank you so much, Dr. Guimond, and also for your grace in my pronunciation of your name, but also the wonderful work that you're doing. Thank you for that description. We'll come back to you, I'm sure, in the Q&A. At this point, I'd like to turn things over to Jack Woodman. Jack, what are you able to tell us about the increase in demand for gender-affirming and related surgeries? How has the pandemic affected those wait times, and what's the effect on people wanting these surgeries?
Thanks so much, Dr. Zacharias. Yes, through COVID, we've obviously seen inequities and the exacerbation of many issues related to trans healthcare that existed long before the pandemic. I'm going to speak to gender-affirming surgeries today, particularly recognizing, of course, that trans healthcare overall, much of which does not involve surgical care, desperately requires attention and resource across the system. So with respect to gender-affirming surgery, there are really limited access points and providers. A lot of people don't know that Women's College Hospital, where I work, is the first public hospital in Canada and the only in Ontario to offer a gender-affirming surgery program. But that said, many people still have to access care outside of the province or even the country. About a third of patients are having surgery outside of Ontario. And most OHIP-funded surgeries occur in high-volume private clinics outside of the province. We know there's an increased risk of surgical complications for people who have to travel over 2 hours for surgery. So this, combined with a lack of ability for in-person consultations prior to and after surgery, really are impacting quality of care and outcomes. The demand for these surgeries, which are deemed medically necessary surgeries, has increased exponentially over the past decade, and there's been little planning at a provincial level to address access and also the resource needs. Just a touch on history. In 2016, we know the Ontario government shifted to a primary care-centered approach for assessment and approvals of surgery, and this was a really important step in reducing the long wait list to achieve the required approvals, but not surprisingly, that bottleneck of waitlists has shifted upstream to surgery. And of course, the pandemic has amplified this, and waits today, depending on the type of surgery, we can see in-province waits between 12 and 24 months for upper surgeries, and unfortunately, at this point, up to 65 months for vaginoplasty in province. The cause of the wait times is multifactorial. In particular, there's an absence of an integrated surgical care pathway in Ontario and a lack of local options, providers, and funded surgical capacity. All of those issues are problematic. Of note, there's also not provincial public wait times data captured and funded volumes to ensure that these needs are being met in Ontario right now. So currently, when we're thinking about the long waiter strategy and funding to address surgical backlogs post-pandemic, we also need to consider work that exists outside of those traditionally captured service models. And to your point, in terms of the impacts on people waiting, trans people in Canada have poorer health outcomes than the country's cisgender population, as my colleagues have noted, and it's largely due to stigma and discrimination, as well as great barriers to accessing healthcare. A fairly recent study showed 45% of individuals who identified as trans or non-binary didn't have their healthcare needs met because of their gender. And again, I'll emphasize, while not every person who identifies as trans will require surgery, we know that for those who do, it can save lives and profoundly impact the quality of life. So wait times for gender-affirming surgery are too long, and really they would not be accepted without immediate action across pretty much any other types of surgical care. And I'll leave it there for now. Dr. Zacharias.
Thank you so much, Jack, for highlighting indeed the mental strain of the wait and the discrimination. So thank you for your valuable work. We are going to move on now to Dr. Kucharski. So Dr. Kucharski, you work on a daily basis with people living with or at risk of HIV. What can you tell us about how the pandemic has affected life for the LGBTQ community? And what are some things that we can change to provide more supportive healthcare for this community? At this point, you're on mute, Dr. Kucharski, but here you go.
Thanks, and thank you very much for having me this morning. First off, just thinking about caring for 2S LGBTQ patients, really central to their care, it just requires compassion and judgment-free care. And I'm very lucky to work at Casey House, which is our HIV hospital for people living with HIV or people at risk for HIV. And that's central to the work that we do there, that we really see people for their humanity and not their disease or illness. And I would say that that keeps me going, and I'm very fortunate to see that on an everyday basis. Our experience during the pandemic, I would say, is somewhat unique. And you've already mentioned that a number of people in the LGBTQ community have a higher burden of substance use and mental health issues. And one of the things that we actually observed, we have a number of clients or patients who use drugs, and we provide them with harm reduction supplies. And we provide harm reduction supplies, and it might be clean needles or pipes or other supplies to help them keep safe if they use substances. And we make those very accessible at our front doors. And what we did notice as the pandemic started was the number of people accessing those harm reduction supplies increased. And we actually have numbers that in the months before the pandemic, in the 6 months before the pandemic started, we gave out an extraordinary number of harm reduction kits. We gave out 4,000 of them, which is mind-boggling to me. But then as the pandemic unfolded, the 6 months after, we gave out more than double that. We gave out 9,000 harm reduction kits. And we were seeing that because other services actually shut down. And us being a hospital, being open 24 hours a day, 7 days a week, we kept open. And so people came to us. And we really looked at that as an opportunity for care for our community and for our patients. A number of these patients may not be people who have HIV, but certainly are at risk for them. So we actually took this as an opportunity to expand our services. And so to think about testing and prevention and screening and whatnot. And so that's something pretty new for Casey House for sure. One of the other things that we did as a hospital that we were thinking about well before the pandemic was we became Ontario's first supervised consumption site. So, or Ontario's first hospital in Ontario to become a supervised consumption site, I should say. And so our patients can legally use substances on site if they're admitted to our hospital or accessing care as part of our day health program. And to me, thinking about testing and things like that, if you use substances, sometimes getting screened or tested for STIs is not your number one priority. Or, if you're needing supplies to help you use substances safely, that may not be your number one priority, getting tested for STDs. So now we're able to actually provide a safe place for people to use their substances or use them in a safer way, but also give them that opportunity to connect with a nurse, a physiotherapist, or other healthcare providers to meet those healthcare needs. And so thinking about our community, that may be one of the reasons why screening for STIs has gone down. I was thinking about other things that have come up in my family practice in terms of screening, and you kind of mentioned that the number of tests went down, and I think there's a multitude of reasons for that. One of them are in the early days of the pandemic. Many services shut down, and we were mostly concentrated on COVID. So that to me makes a lot of sense why screening or testing for STIs went down. But I also still see today, as services opened up, people and patients still call our office and say, "Are you open? Are you seeing patients?" And I still think there is some perception in the public that services aren't fully open and operational, so people don't have that permission to get out, get screened and tested. The other two reasons why I think people may not be getting tested during the pandemic, they actually may have reduced their sexual activity, and therefore, intuitively they don't need as much screening. But getting back to that stigma, for those people who were sexually active during the pandemic, there may have been that stigma that people have faced. We were told to stay away from people, to stay home. And so when people were sexually active, I think that they did face some stigma going into their healthcare provider and asking for testing. So I think that, if we're thinking about caring for LGBTQ people, really being compassionate and judgment-free is the bottom line for me in helping people get healthcare. Thank you.
Thank you. Thank you, Dr. Kucharski. Very valuable work you're doing, and I know we'll come back to you in a Q&A. At this point, finally, we'll now hear from Dr. Borns. Dr. Borns, you and Dr. Kucharski, I understand, have written a textbook on LGBTQ health that's coming out this month. What are you able to tell us about the progress that's been made in this area of healthcare over the last 20 years? What barriers still exist? And how can we create, from your point of view, more positive healthcare for LGBTQ patients, both in terms of the experience and outcomes? Dr. Borns?
Thanks, Dr. Zacharias. Yeah, as you said, Ed and I have just birthed a textbook on this topic, and sometimes it's hard to distill down what you've spent hours on into high-level points. But I actually also really wanted to first share a little bit of the sort of more personal experience of the impact of the pandemic that I'm seeing in my interaction with patients as a family physician on the 2S LGBTQ unit at Sherburne Health. And so, I mean, you mentioned the barriers to care, and we know that that has been an issue for decades. And we also know and talk about in the book how that has improved. But I think sometimes there's a tendency to focus on, look how different things are. Look how much better things are. Oh, there's a pride, sticker in my doctor's office and things like that. But I think we also need to recognize that there's still a long way to go. There's still a lot of discrimination, stigma, and barriers to care and impact on the health of our population. And so we know that the pandemic has really created additional challenges for all marginalized populations. And what I've seen in my practice is that a lot of my patients had to make the difficult choice to actually move out of the urban center, out of Toronto, because of financial or occupational reasons or looking after family and lack of affordable housing. They've had to move back into suburban or urban areas where access to their inclusive healthcare teams, support services, and social networks is impaired. So it is quite challenging. And so that is definitely affected feelings of isolation and obviously therefore mental health and wellness. While the situation is improving to some degree in accessing gender-affirming treatments, while providers are learning more all over the province about how to do this work, there are still significant gaps in care. And when trans folks are moving outside of the city, they're often having a lot of difficulty finding a family physician that is able to meet their medical needs or familiar with their care. I also just wanted to highlight the impact on youth, because they're another subset that has been particularly hard hit, the youth in our community. Because I think for a number of reasons, but I think during adolescence is that feeling of belonging is so important to mental health and wellness at that stage of life. And when you're coming out and seeking mentorship and peer support. So the isolation that came from the pandemic restrictions, often forcing youth sort of to spend time with potentially unsupportive family members, sorry, I just lost my train of thought for a second. Yeah, so again, things are improving in terms of acceptance of young people coming out in their families. And this is really very important in their well-being, we know. But it's not the experience of every youth that they are, that their families of origin are supportive of their identities. So having to move back home, having to spend more time at home has been very difficult. And the pausing of community programs, those, for example, provided by organizations such as Supporting Our Youth, when they stopped having access to in-person programming, they stopped having access to warm meals, to STI screening, to mentors and to mental health supports. And even before the pandemic, there's a study that came out this month actually in CMAJ based on data from 2019. It showed that trans and non-binary youth were at a 5-fold higher risk of suicidal ideation, a 7.6-fold higher risk of suicide attempts than their cisgender peers. And sexual minority youth were 2.5 to 3.56 times the risk of suicidal ideation versus heterosexual peers, and 2 to 3.3 times the risk of suicidal attempt. So clearly a population at risk. Jack spoke very eloquently about the challenges in accessing gender-affirming surgery. And I want to echo that, and I see the suffering of my patients every day in that regard. And I also just wanted to highlight that it's not just the surgeries and the wait time for surgeries that's an issue. So we've deemed medical transition for trans and non-binary folks as a medically necessary service, and yet there are aspects of this transition that are not accessible. So, for example, I have a patient who was approved for a phalloplasty surgery 5 years ago, and has been unable to afford the electrolysis that would be required to prior to that surgery to prepare the donor site, and therefore he's been unable to access that surgery. And that's one example of pieces of the process that are not covered and that can cause significant delay and distress for patients. And so in regards to your question about what can we do, I think I'd really like to punt that back to the whole panel, because these are really challenging questions. And Tim's HQ detailing of what HQ is doing is really exciting. I think we absolutely need more attention, more funding to these issues. And I would love to hear the ideas of the other panelists on how we're going to move forward to help our population.
Thank you so much, Dr. Borns. And indeed, thank you to all of you for your compassionate, passionate, skilled, brilliant work. I mean, there are still barriers that exist to this healthcare and this population particularly, but you are all very inspiring in your work, and I just want to thank you. And so at this point, we are going to turn to the Q&A, and OMA's Emily English is going to moderate the Q&A. So please, many questions have already come into the chat. I think we're already on 17 questions. So we're going to try to cover several of them, maybe group them together as per their theme. If we don't get to your questions in due time, the media team will follow up with you. You can also email media@oma.org. We'll put that in the chat for sure with additional requests for interviews. And we will also have a recording of the session available later on this afternoon. So at this point, I'll turn things over to Emily.
Thank you, Dr. Zacharias, and thanks again to all our panelists. We do have a question from the media. Dr. Kucharski, I'm going to direct it to you since I know you are also a family doctor and recently co-edited a textbook on LGBTQ health along with Dr. Borns. So the question is, could you talk about the impact on the LGBTQ plus community in smaller rural areas, places like Northwestern Ontario, where services may be hundreds of kilometers away, and we know that region's facing a doctor shortage. Could you talk to us a little bit about the impact there?
I can speak a little bit to that, but not working in a rural community. I may not have as close a sense as one may experience, but we do have a number of patients, I think Amy mentioned this already, that have moved out of the city. And for any patient, not just LGBTQ2S patients, finding a new primary care provider, there's been a number of providers who've retired, so making access challenging. At baseline, I would say, is one of the things that I think about. The other thing is, caring for our patients in a competent manner from a cultural competency, or sometimes we even say cultural proficiency, and having that knowledge, skills, and judgment to care for LGBTQ people may be lacking. But I'm pleased to see organizations like Rainbow Health Ontario has really reached out to communities across Ontario, and they really, over the past 2 decades, have built knowledge in these smaller communities. And so people can get trans care in Thunder Bay and in Windsor now, and competently so. So I'm really pleased to see that there's been some movement on that, and I think we're doing a much better job. But I think in general, whether you're LGBTQ2S or not, just getting access to healthcare in those rural communities is going to be a challenge.
Thank you. And the next question is for Dr. Borns. Is there a role for medical schools in addressing the needs of the LGBTQ plus community through education of new doctors? And is that happening currently?
Yeah, that's an excellent question, and my unreserved answer is absolutely yes. It's in medical school where we as providers start to understand what it is we're responsible to know and to be able to do. And if it's communicated to students and trainees early in their training that there's an expectation that we will be able to provide culturally and clinically competent care to patients regardless of their sexual orientation and gender identity, then I think that lays the foundation and the attitudes that are needed to create a health workforce that is capable of doing that. And I think goes against the assumption that, for example, trans care lies in the hands of a few specialists. That is not something that we as family doctors need to know about. And so there has been work that has been done. And kudos, as always, to young people and students who keep pushing things forward when they see the gaps in their education. But I think it's also now really also incumbent on staff and faculty to push forward, ensuring these competencies are taught in medical school and in residency programs. And right now, there doesn't exist any kind of national standard as to what those competencies might be. And every school is left to decide what they choose to teach on this topic. And therefore, you see quite a bit of variability. And to address this gap, and also my hope in creating future leaders that can move this work forward, is that I direct a program to teach family medicine resident graduates enhanced skills in the area of caring for 2S LGBTQ people, and create their confidence and advocacy and leadership skills in order to not only provide the care, but also to support our peers in providing that care, educate our peers, and be involved in medical training.
Thank you for that answer. We have another question from the press now. So I'm going to actually ask each panelist to give a very quick answer on this one. And we'll start with you, Dr. Guimond, if we can. So the question is, what's your message to the province overall in terms of what more is needed?
So I would say that one of the things when we look across the world, in large urban centers, there tends to be LGBT healthcare facilities. And some of that is facilities targeted towards mental health care and substance use care. And we need more of that, I would argue, in the province. And so I think it will be helpful if the government can increase investment in mental health care generally, but also be very aware of the way that race and sexuality and gender influence this, and there may be need for targeted dollars to help increase the supports in those areas.
Thank you. And Dr. Kucharski, what do you think? What would you like to see from the province? What more is needed?
I think that I'm going to stick with my theme of people who use substances. And this is a lot of the work that we've been doing at Casey House, is really supporting people to be able to use substances safely and allow them to access healthcare services. And as I mentioned before, being Ontario's first hospital to have a supervised consumption site, I'd actually like to see that become more pervasive across the province, and other supports for people who use substances, and to support them and their mental health.
Thank you. And Jack Woodman, what are your thoughts on what more is needed?
Think of generations out and how sexual orientation and gender identity are going to be perceived by next generations. And it's going to be very different than it is today. And for governments to start to think about the trajectory of care through the lifespan of LGBTQ people, we don't currently have a provincial strategy. And I think that would be a really good starting place. British Columbia, for example, in Transcare BC, has established a really effective strategy. And the key is that then funding also gets applied, because we have a clear path and we know where the funding needs to sit. And that's going to be at all levels and ages of care. And of course, through all of the primary care and specialty care that's required.
Thank you. And Dr. Borns, what are your thoughts?
Yeah, that's tough, because I agree with every single one of those points. So coming to me last, I think I would just say that at the root of a lot of these gaps and barriers is stigma and discrimination, homophobia and transphobia. And I think we need to keep working on destigmatizing these differences in our experiences of gender and sexuality. And I think that has to go from all the way from how we talk about sex and sexuality and gender in our schools to our children, throughout to our adolescents and adults. And so my suggestion would be to keep pushing for more improvements. And as I said, to not become complacent. We can be really celebratory that our sports teams have a big Pride weekend, for example, and yet none of the players are wearing any kind of indicators on their uniforms the way they might for breast cancer or prostate cancer. And one might hope that one day there won't be controversy around that.
Thank you. And Dr. Zacharias, is there anything you would like to add on things that you would like to see from the province?
Absolutely. Thank you, Emily. I mean, here at the Ontario Medical Association, given the time of our recent provincial election, it felt like the ears were open as to what needs to be fixed. What are the gaps that the pandemic exposed in our healthcare system? And so we have been speaking loudly and clearly, actually, in a very concise document called our 5-point plan, our prescription for Ontario. There we outline the key priorities. And given the panel today and our topic today, I think about 3 key priorities highlighted in our prescription for Ontario: catching up on the backlog of surgeries and procedures. We talked about that here today. And so here's a particular community that I think has been backlogged significantly. I mean, we know this astounding number, 22 million patient care procedures have been backlogged in the province while we dealt with the crisis of COVID. So in there, we need to be doing some catching up. And also the investment in mental health and addictions. And so that needs to be, to the tune of publicly funded, team-based, community integrated care, some of which we've talked about here today is happening, but needs to happen more. And then lastly, providing everyone in Ontario, and the emphasis is on everyone in Ontario, a family doctor. 1.3 million people in Ontario don't have a family doctor. That's urban, rural, remote. That's a widespread problem. And then not only a family doctor, that is that trusted relationship for preventative, complex, integrated, consultant, point them to the consultant care, but a team of healthcare providers wrapped around individuals that is digitally connected also seamlessly, right? That our computers wouldn't be glitchy. So we have a strategy. The recommendations are very specific in the prescription for Ontario. That's what the province needs to do, and it would have an amazing impact if indeed those recommendations are implemented. So as Ontario's doctors have been saying all along, we intend to work with government to see these recommendations through.
Thank you. And we have a question from CBC. I'm going to direct it first to Dr. Borns, but perhaps Jack Woodman, you may have a few things that you might like to add on this one as well. So the question from CBC is, could you expand on the issues that you highlighted, Dr. Borns, with the story about the patient who's been waiting years for surgery? Is there a lot not covered, and how expensive is this?
So the example that I brought up was specifically around hair removal. So hair removal, particularly for trans populations, is often a required part of a medical transition, both in terms of facial appearances, but also in terms of preparing donor sites for surgery. And that was an example of one of the components of the transition process that becomes a challenge for people, and can actually stop the trajectory of the transition process for somebody. So in the case that I mentioned, the patient was approved for a phalloplasty procedure, requires electrolysis of the forearm as a donor site. To my knowledge, the cost is somewhere between $1,000 and $2,000 for the repeated procedures that would be needed to obtain the desired results. And I may want to fact check that, but that's my my general understanding about the cost. And it's just something that a lot of people who don't have that don't have a lot of disposable income can afford. And there are other examples of procedures that are important for some people as part of their transition that are not covered. Would include vocal therapy in order to feminize or masculinize the voice. The contouring of a male appearing chest, so mastectomy is covered, but not the contouring of the chest. Breast augmentation for trans women, tracheal shave surgeries. There's a number. I highlighted the electrolysis one because I feel like it's really important, but there really exists no method for estheticians or people who perform electrolysis to bill OHIP, and so it feels like a bit of an uphill battle in trying to address that.
Thank you. And I'm going to ask Jack Woodman from Women's College Hospital if there's anything that you might like to add, because I know that you were instrumental in bringing the transition-related surgery program to Women's College Hospital. So perhaps if you might like to expand on that, or also tell us what kind of system change you might need to see to provide better care for the trans community.
Mm-hmm. Yeah, I mean, Dr. Borns has said it and covered it very well. I just say, this is something that differs province to province. And in Ontario, we haven't modernized the care and looked at those OHIP fees about what might be covered and needed in this population for, optimal or best practice care. So I certainly think there's time for that. There are certain things even that we do provide that aren't that don't even have codes for billing. So we need to really take a good look in this province at those codes and make sure that we are addressing that. You know, in terms of the system question that you just asked, one of the things I think that we haven't covered, which is a little more dry and I think less discussed as things like stigma and discrimination, is the data collection. You know, we don't have good health administrative data to capture, you know, gender identity, sex assigned at birth, and those sorts of things. So even to know sometimes that information is challenging. And then even beyond that, when we're looking at things like wait times, there's not a provincial collection of that. So there's, you know, wait times at the private clinic, there's wait times at each organization, but we don't have a provincial view on what's happening in these populations. So I think that would be a really, really important aspect that we work towards.
Thank you very much for that answer. And I want to throw it over to Dr. Tim Guimond. If there's anything that you would like to add on to that through your experiences with CAMH or at HQ Clinic.
Yeah, I think I really agree with Jack's point. The collection of information is very difficult, just to know in what ways are our community impacted, right? So to know what are the specific needs and care that's missing, that goes unmet for trans community, for non-binary individuals, for sexual minorities. These are often collected in different ways in different environments. They don't make their way back to administrative data sources often. And so from an analysis point of view of trying to figure out where do we need to spend our resources, where do we need to take our human resources and address the biggest need, the information can be missing. You know, we rely on studies in other jurisdictions to try to figure out what might be going on. So like Dr. Kucharski was saying earlier, it's not clear if people adhered well to our social distancing and had less sex during COVID. There's some studies in regions of the States that suggest that some people were having more sex. So we don't know often those pieces of information that you would think would be commonly available. We certainly, even wait times, the wait times at Rainbow Services, when I was there from early in my career, from 2008 to 2011, we had no wait list. And when I heard at the beginning of the pandemic, they still did not have a wait list. And that wait list grew and grew till we were at about a year and a bit of some people waiting. We had to make some radical shifts to the way we offered services to make sure that we could get people in sooner. Because we also know that the longer you wait to get into a treatment, the more you suffer, the more burden, and the harder the care might end up being later. And so it's in everyone's best interest to address things quickly. And when we don't understand these wait times in lots of environments, we don't know if everyone's having the same impact or if one program is being overburdened, and we could shift where people get care. This is very important in rural and suburban areas where, like we've described, you might have enough people to build an LGBTQ specific treatment in a downtown core, but there are people living across the province who are part of sexual and gender minorities. Now, what COVID has taught many of us is that we can actually offer the care remotely sometimes. So one thing that's been very heartwarming for us at Rainbow Services within CAMH is to see people who would otherwise not be able to come to Toronto join remotely. So someone who's living in St. Catharines or living in a very remote part of Northern Ontario can join with one of our groups, get supports, and meet with other people who, like themselves, do face the social isolation, and maybe even more so in their more remote community. So these are all things I think better data would serve us, and just having the ability to change the way we offer treatments, as we've seen in COVID, maybe something we see for years now that really actually help a lot of sexual and gender minority individuals get access to care in ways they need. Some care has to be done in person, right? Your sexually transmitted infection is not going to be treated over a camera, but maybe your mental health care some parts of that in your substance use care, some of that could actually be done quite well in new ways that we're doing. And so the investment in virtual care and maintaining that access is really important, I think.
Thank you. And the next question is going to go to Dr. Ed Kocharsky. What needs to be done to further reduce barriers to HIV testing?
I think a lot can be done, and we've already talked a little bit about stigma. And in this day, you know, I think we had 40 years of HIV in North America last year, and still to this day, there's such a stigma associated with HIV. So I think really reducing that stigma makes a lot of sense. We did a survey at Casey House, and participants said that over 50% of people would not eat a meal prepared by someone with HIV. So if that speaks to, you know, stigma, I don't know what else does. So I think reducing that stigma and knowing that HIV is a very treatable disease. And we now have evidence that people who have HIV who are adequately treated, they can actually live longer than most people in the general population. And that might be because they're getting regular care and prevention at points along the way. Some of the other things that, you know, we've already talked about is just having that welcoming, judgment-free, destigmatized environment for people who might be at risk for HIV. We now have self-testing for HIV. And I think that's an opportunity that is not as promoted. And I think we could do a lot more there. And then just even thinking about HIV as a routine, or testing for HIV as a routine part of care, that this is something that anybody's at risk for. And so for a regular STI screen, having that as part of what our physicians are doing would be one of the ways to reduce barriers to care too.
Thank you very much. And we have one last question I'm going to ask Dr. Zacharias to answer. So Dr. Zacharias, we've mentioned things already like lack of access to mental health services and reduced STI testing, the surgical backlog. Can you expand a little bit on other types of medical services that might have been missed during the pandemic and how they're showing up within our healthcare system?
Absolutely. Thank you, Emily. So, I mean, we've shared the number here, 22 million. That's up 1 million since we last checked in February of this year as to how many procedures, surgeries have been backlogged. So in there, we've covered some of them. But what we haven't talked about here today is routine school-based vaccinations for children, and even just the regular checkups, which links to my last point as to really an important aspect of what's been missed is cancer screening. So people have not come in for their mammograms. They've not come in for their colonoscopies. They've not come in for their simple mole checks. And so, I mean, my background is family emergency medicine. I know how important it is and how worrisome it can be if you have had, you know, a mole on your skin that you wonder now looks different. And is this indeed a cancer? That requires a doctor's opinion. And so you can imagine just that one sort of simple missed appointment could translate then into many, many, many more appointments if now this is at an advanced stage. And people are just showing up sicker as a result of these missed appointments. And people have become more dysfunctional as a result of their missed knee replacement surgery or hip replacement surgery, becoming more immobilized, then the overlay of the mental health strain, the effect on the family, the strain on their relationships, the impact on their employment. I mean, the healthcare system is absolutely integral to the other systems that the province wants to hold up, including the economy. And it's a priority to Ontarians to catch up on the backlog. All the things we've outlined in the prescription, I've highlighted a bit here today. I'm happy to talk about that more. But indeed, these are really vital points that the panelists have all made today, and this one that I'm making now. So thank you, Emily, for moderating.
Well, thank you. And thank you to all our panelists. It really was a really insightful conversation and appreciate everybody's time. I'm going to throw it back to Dr. Rose Zacharias, OMA President, for just some brief closing remarks.
Thank you, Emily. So thank you very much to our esteemed panelists, obviously in your own area of expertise, but contributing to the inequity and lack of access to care for our LGBTQ population of people. And so I want to thank you very much for sharing your insights today. Also for members of the media that have been here and waiting and asking your very insightful questions in the chat. We know the effects of the pandemic on our physical and mental health have not been equal. And so the reason we're highlighting the LGBTQ population is this is a population of people that have been disproportionately affected, and we need to remedy that if we call ourselves the healthcare providers that we are. And yet it's a team sport. We need levels of government and all healthcare stakeholders to invest in the solutions here. Every inch gained in closing the gap is a step towards a more inclusive province